forward. Thank you everybody for coming to August BHA Technology Office Hours. So for those of you, if you haven't been in office hours before, we host this meeting for behavioral health providers, specifically looking at data and administration teams to get updates and changes and improvements to the BHA managed technology systems, to surface and discuss questions with the BHA tech team, to provide feedback and expertise on ongoing tech efforts, and to understand opportunities to further engage with the BHA technology team from a provider perspective. Again, like I said, I posted the For Providers page in the chat. That's where you can view all past office hours from this year if you're curious to hear about the topics we discussed earlier in the year. A couple of plugs, and all of these links are in the chat as well. We have a hot topic survey that we use to prepare for our Q&A section of this meeting. So if you ever have a topic that you want to discuss, feel free to note that in that survey, and we'll come prepared the next month to discuss that topic. We're using the BHA Provider Resources website as a source of truth for office hours. So you can find agendas, a Zoom registration meeting link there, which I've also linked to in the chat. And then as always, you can contact this email for provider support if you have any questions. We sent out our agenda via our Google group. So we have a couple of quick updates to go over. I'll hand it over to Dan to give a quick update on the BHCNE project. And then I'll take over from him to go over a couple of details around the administrative burden CCAR DACODS research, as well as some research being conducted on an upcoming referrals platform that you may or may not have heard about, and user testing for that in progress platform. And then we have our open discussion and Q&A section of the day. And so that's when we really open it up to you to ask questions of us. And we also usually bring a topic to kick us off. So we have the BHA website as our topic of the month for this month. So with that, I'm going to hand it over to Dan to walk us through a couple updates on the BHCNE project.
Hello, everyone. Really just a couple of quick updates today. And of course, anytime there's other questions, just shoot them out. From the BHCNE perspective, enrollment is open for any of the MSOs and ASOs. We actually had one MSO drop in an application without telling us, so we're tracking to see what happened to that one. But the system is still having a bit of a challenge on an ASO application submitted by Signal. So HICBUF is working to figure out what went wrong in that particular process. But applications for enrollment as a type 91 or 92 provider can still be taken in the system. Still holding off on CMHCs as enrollment for now, just like before. So next slide. As part of the enrollment, the intent was to have all of the subcontractors to the ASOs and MSOs enroll in the interchange as well. So that caused the creation of the BHA as a new payer in the system. And what that does is triggers, the provider participation agreement to get you access into the interchange provider portal, to be able to recognize you as an entity if encounters are submitted with your name on them, et cetera. And also makes available this operational support group we have with HICBUF to support any issues with getting people enrolled and with getting encounters submitted. That BHA payer click box in the interchange enrollment is available to any provider who goes in to enroll in the interchange. So it's available to all Medicaid providers, all BHA providers. On the Medicaid side, an entity or an individual, they have to enroll as individuals as well. So anybody can select BHA as a payer. I wanted to make that known to you. It's kind of the way the system works. with BHA payer being exposed in addition to the Title 19 payer. And people who select that start receiving letters for successful or unsuccessful enrollment, depending on the circumstances, as a BHA-funded service provider. Fundamentally, it's the way the system works, but it does not change anything relative to the contractual arrangement the BHA has with providers. I just wanted to make sure you're aware of that. The BHA funded services is an older term that we used when we started the project that was kind of replaced with BHA community services in the eligibility aspect of the BHCNE project. But if you start getting questions about, hey, wait a minute, I selected BHA payer, what does that mean? Who do I submit invoices to, et cetera? If an entity does not have a direct or indirect contract to the BHA, they don't get paid by the BHA. So we have some communications we need to do to kind of clean that up. But with this larger group of providers, I just wanted to expose that to you. So just one aspect of the system, you know, being the interchange and supporting Medicaid. Next slide. On the pilot status, we're still working through with Signal. Like I've said before, they successfully enrolled as an MSO. They've got multiple regions, so just a few administrative challenges of getting all their MSO regions enrolled, but we did have an ASO enrollment rejection. You have to certify, you know, via ClickBox that you have the appropriate licenses, and because there's no license associated with being an ASO, they clicked all the right boxes, but for some reason the application still got rejected. So HCPF is going through the processing to figure out what the issue is there. But again, it doesn't stop us from other people starting to enroll as an MSO or an ASO. That itself doesn't trigger any additional action, just gets you into the system with that particular access, starts getting you in the tracking with the support group we have with HCPF. We have created successful encounter records in the system. And the next step for us is to work on supporting documentation around that. Where do we put BHA unique information in an encounter? Where do we put special studies codes? What information that may be required in a 837P loop for Medicaid that's not required for BHA, for example. So we're putting all that documentation together right now, working again, largely from the work done by Signal as part of the pilot, but we have regular discussions going on about that. As soon as we start producing some documentation, we'll send it out to a small group of people for some initial review, and then it'll, you know, be a broader review for every provider, because it becomes a set of requirements for how to submit BHA encounters. I don't have a slide on it, but the next logical question that comes up is on the Peak Pro access. And I've posed questions to HCPF, and I've been delinquent in pounding them for answers. How long is the training? What's the modality of the training? How do you get accounts? Does a provider control sub-accounts, if you will, to individual people? So I'm delinquent in getting all that information, but I just wanted to point out to you that's still tracking with HCPF, so we can get that information and get people access to Peak Pro. Then you can start, you know, seeing the functionality and how you can best use it in your organizations. So that's the quick update I have. We did get a bunch of questions submitted by one provider who couldn't be on this call. So to be complete and making sure everybody has the same information, I'm going to put answers together for all of their questions and send it out to the whole Google email group. Get that done tomorrow. So I think everybody, 200 whatever people that are on that group will can expect to see that set of answers. Some of it overlaps what I provided today. Some of it is slightly different questions, I think, but you'll all see that tomorrow. Any questions at this point for BHCNE? Okay, I know it was a pretty quick update, but if you have other questions, I'm available anytime. I think you've all seen my email 100 times, but feel free to reach out. My cell phone number's on the email signature line, so feel free to pick up the phone and call me as well. Thanks.
Thanks, Dan. I also want to say that I posted the link. We have a FAQ document on this project that contains a lot more info, so that's also in the chat.
Thanks for bringing that up, Abigail. I was going to mention too that there were some other documents prepared in conjunction with or in collaboration with HICPUF, because the BHA programs are now visible in CBMS. The counties have had a lot of different questions, so those documents may also provide a lot of answers to questions you have or answers to questions others may be bringing you. So I'll work with Abigail to put those documents in some place that you can get access to as well. They're publicly available, but probably not advertised to anybody on this call unless you have to be a county eligibility worker on the side. But we'll get that out as well. Thanks for bringing that up, Abigail. It triggered my memory.
Yeah, of course. All right. So any questions on BHCNE before we move on to the next topic, which is the administrative burden CCAR DACODS research we've been working on? And questions can be in chat, or you can come off of mute, however you would like to communicate. Okay, well, if you think of anything, we have a Q&A section at the end of the hour, so feel free to put it in chat and we can address it and during that discussion time. All right, so our next topic for today is the administrative burden CCAR DACODS research that our team has been working on over the past couple of months. So if you haven't been to an office hours before or haven't heard us talk about this, the scope of this research is really to look into the CCAR and DACODS report types and expand the work that had been done in the Compass initiative to ensure and kind of check to make sure that those findings were up to date and evaluate a path forward and a roadmap forward based on research. So we conducted a number of interviews with, I think, around 20 providers. Some of you on the call participated in those interviews, as well as extensive secondary research. So I wanted to give a little bit of a status update on this project, and then also get some live feedback from you on some visual artifacts that are coming out of that research. So our active research is complete. Like I said, I think we talked with around 20 providers doing hour-long interviews and hour-long virtual site visits, which is just a fancy way of saying sitting with providers as they were filling out those reports and seeing firsthand what that entry process looks like. Our synthesis process is also complete. So we're in the process of doing internal reviews on the recommendations that came out of that research. And are hoping to get in a good spot and good levels of approval on that in the next week or so, and then are looking to start to share out more externally. So doing like an official presentation with this group, potentially have official presentations in the provider town hall, crisis convening, as well as some other provider meetings that the BHA puts on. And then sending out and putting recordings of the research and the deck on the provider's website at all. So anybody who wants those updates in short order should be able to find those research artifacts in a couple of different places. And implementation of those recommendations won't start until we're able to sort of validate our findings with all of you in a variety of ways. So all that to say, we'll have kind of more formal presentations and a more formal report for you all to look at, including a draft roadmap and timeline for those implementation processes. But one of the things we wanted to get your thoughts on in the meantime, and we did this at office hours previously for the bed capacity tracker, is we have a couple of journey maps. And again, journey maps are visual depictions of processes and services across a variety of actors and actions. So we have 2 journey maps that we wanted to get your feedback on today about if we got anything wrong or if it's generally looking correctly. And the way that we've split out these 2 journey maps is between high tech resource providers and lower tech resource providers, because we know that depending on what the setup of your tech system and tech team is, the journey map for submitting CCAR and DACODS reports can be quite different. So this is just a slide prefacing how we're defining high-tech resource providers or low-tech resource providers. So I'll just go through this quickly for context. So when we think about a higher tech resource provider, they typically have full EHRs, customized EHR modules for state and federal reporting, budget for potential API capabilities, a dedicated tech, data, and finance team, dedicated grant and contracts teams that monitor reporting requirements, and high-speed Wi-Fi. When we're thinking about provider organizations that might have lower tech resourcing, you could think about, having a simple EHR and no, if any, customizations, not a ton of budget for tech infrastructure, clinicians and front desk staff taking on data and tech duties, grant and contract management and related reporting is added to someone's job or responsibility. Some reporting is still completed by hand, and there's that potential for limited Wi-Fi broadband. Any questions about that distinction between higher, lower tech resource providers, or any feedback that anybody has on like how we're making that distinction? Okay. And the reason that we really dug into this is we know that there is such a wide swath of different tech setups for behavioral health providers across Colorado. So we know that whatever solutions and recommendations we put forward need to work for the highest and lowest levels of tech resourcing when it comes to improvements to the CCAR DACODS reports. Okay, so the next slide I'm going to share, this is a visual depiction of what we feel is the current state of a provider with lower tech resourcing in how they submit, collect, and report CCAR and DACODS reports. So you can see that there's 3 different actors in this visualization. There's the clinic, the clinician, clinician supervisors, and then front desk and admin staff. And you can review color-coded steps for each of those actors across the 3 high-level phases that we identified for CCAR and DACODS reporting. And those 3 high-level steps are the collection of the information. So during the client appointment, how that data is being collected with the client present. Then we have the reporting phase, which is where the data is actually entered into the EHR, into the state systems. And then we have the auditing phase, which for a lower tech resourced provider, often we found that there was not a ton of resources for auditing to occur. And by auditing, I mean looking at the similarities and differences in the data that the state has versus the data that a provider has in their own internal systems. So I would just love y'all to take a few minutes to look at this diagram and this user journey and say if we got anything wrong or if this generally looks correct in the process that you might take to collect, report, and submit CCAR DACODS reports. All right, quiet group today. maybe we could do, if this generally looks correct, maybe a round of thumbs up. Okay, I'm seeing a few thumbs up.
I'm a high-tech provider, I think, so
Yep.
I'm not saying anything yet.
Okay, all right. Well, maybe I saw a few thumbs up, and let's maybe go to the high-tech resourcing. So same general phases: collection, reporting, and auditing. And you'll notice now that we both have, we have the clinician like we have for lower tech resourcing, but now we also have a dedicated role for a data tech team and a finance and contracting team. So I'll give folks a few minutes to look through this and see if there's any feedback. So maybe thumbs up if this looks generally right. Or if you have any nuances you would want us to add, feel free to come off mute or go in the chat. Cool. Love thumbs up. Got it. Okay, Kevin had the point that on the lower tech resourcing, sometimes admin staff enters the data into the system. And by system, Kevin, do you mean EHR instead of the clinician? TMS? Got it. Great. Yeah, that's a great nuance. We definitely heard that. Cool. Any final feedback on these diagrams? Love the thumbs up. That feels good. So yeah, more to come here. I'm glad for that gut check that generally this feels pretty good. These journey maps will help us to evaluate where efficiencies can occur, and where the state might take on more of the administrative burden that we know providers are definitely experiencing around this report type. So thank you for your feedback, your continued feedback, and over the next couple of weeks, we'll have some more concrete outcomes to share. So appreciate your patience.
Abigail,
Yep.
This is Werner. The only thing that we try to do is we try to incorporate the error resolution and error checking into the data collection itself at the front end, at the entry point for the clinician, so we don't have to go through a extensive error correction process down the road.
Got it. Yeah, and Werner, do you do that through customizations to your EHR?
Yeah, we basically have the whole CCA form in the EHR and the data validation for the CCA in the EHR.
Yeah, that's a great point. We heard a couple of people, had built that level of customization. So we know there's a couple of different ways that folks approach error resolution. So that's awesome. Cool. Great. So we can go on to our next topic, which is another body of work that I'm sure many of you are familiar with, because I think lots of folks have either been interviewed or part of our initial user testing group, but previously known as Bed Capacity Tracker. We have now transitioned the name of that project into Referrals Platform, which will include bed availability information. We're going through a couple of different phases of this project right now, and are doing some research initiatives in parallel with one another. So right now we are, iteratively building and doing user testing on a beta version of this referrals platform. And that usability research is in progress and will continue up until a public launch in January of 2024. So we've completed our first smaller group of test users and are currently recruiting our group 2 of test users for this system. I'll have a slide in just a minute about how you can participate in that if you're interested. So that these kind of like group user testing opportunities will continue up until January. And we also separately are doing a sprint of research on referrals that will involve interviews as well as an engagement with BHAC, our Lived Experience Advisory Council, where we're going to be engaging folks with lived behavioral health experience in how this type of referrals platform might influence how they receive behavioral health care in Colorado. So very much all of this is in progress. For our upcoming research with more in-depth interviews with providers, we have a number of research objectives. So if you remember earlier in the year when we were doing a similar initiative on bed capacity tracking, we were really focused on like how folks are defining beds, how folks to define how many beds they have available, how that, intersects with a milieu on a unit. And that research really led us to understanding that we needed to prioritize features and functionalities around the referrals process, and that a standalone bed capacity tracker wouldn't be of much assistance to providers because it wouldn't have the appropriate level of unit information in order to facilitate a referrals, which is really ultimately the goal of the legislation that drives this work. So we spent a good deal of time talking about bed availability and definitions of bed and capacity. And now we're really wanting to dive in deep onto what the referrals process looks like, what is included in a client packet, what are the barriers to effective referrals, how does pre-authorization and payment factor into that? What of those pieces of data and information should be housed in a state-supported platform versus what needs to happen in a face-to-face or a phone call conversation? So that's the type of questions we're hoping to unpack in this upcoming referrals platform research. And then we have, user testing. So this is really bringing test users into the beta version of this platform and getting live feedback as we ask folks to go through different tasks and actions that they might complete within the platform. So like I said, we did finish our first group of user testing earlier this month. And the findings from that testing can be found in the link that I just posted in the chat. If you are interested in being part of the second group of test users, please shoot me a note, and my email is on the screen with the subject line usability testing, and I can include you in that second group. And then my fun question before we transition into the Q&A section for today is one of the findings that we had from the referrals, the first group of test users was that the term referrals or the name referrals platform was confusing because there's lots of different definitions for what a referral is across the behavioral health space. So I wanted to ask y'all, if you had to put your brain into be a branding, a marketing person, what might you think would be a better name for this platform that would make more sense to you? And it doesn't have to be like a polished name, but even if just like you feel like there's a better word than referrals, or, it should be, behavioral health referrals or residential treatment referrals, like that more specificity is also fair game. Placement tracker. That's great. Yep. Referral tracker. Do other folks feel that like placement is a more intuitive word or maybe a better word than referrals? I like it though. Cool. Tamara, can you talk to me about tracker and why that appeals to you?
I think it's just something maybe that I use internally for myself to know where things are and know who's going where and what's available to me. So I guess that's why it occurred to me for that.
That makes sense. So what you currently use to manage referrals today, you call internally a tracker.
I would have, yes.
Yes, you would have. Okay. Got it. And Marcia said to me as the Ray, a referral is a possible placement and a placement is an actual admission. That's really helpful, Marcia. Thank you. Okay, so it's sounding like the placement might be a more intuitive word to some folks. I love that. Cool. Any final thoughts on, language, better words? It doesn't even have to be a name necessarily, but just like if you were skimming a website and, what would you be looking for if you were looking for this type of resource? Cool. Mona agrees with placement. It's maybe too generalized for this purpose. That's awesome. Okay. I love that. I'm glad that I asked. That is super clarifying. And this will not be the last time that I ask that question either. And I'll likely, in a more holistic kind of like branding survey, might send some questions out later in our process. Okay. Okay, Kevin. Yeah. So Kevin, good question about TMS. And do you mean like placements into TMS? So TMS, I think, as part of the work that we talked about around administrative burden will eventually be sunset in favor of whatever solution or recommendation roadmap goes forward with that work. Definitely hear you on like so many different databases. I think one of the things that we thought about in the admin burden CCAR DACOD's reporting is, how do we centralize this in one system? Certainly, so you're not having to go to two different places. But I also think that the idea of consolidation of entry points for provider services technology from the BHA overall is something that we're thinking about. So what does that front door for providers look like, and how do we make that the most like streamlined process possible for the least amount of logins? So that is definitely something top of mind for us. Great question. All right. So before I kind of open it up for the topic that I have prepared, I wanted to give an opportunity for folks to just do a Q&A. I'll stop sharing my screen so I can see all of you. Does anybody have any questions? And it doesn't have to be about anything that we covered today, but just in general, anything that's been bubbling up that you want to bring to this team. And if we can't answer it, we can certainly hunt down an answer. Okay, well, if no one has any questions, that's all good. And you can keep thinking about them while I share up the last topic that I have to talk about today, which is the BHA website. So one of the things that we're working on for BHA provider services is really thinking about, orienting the way that providers navigate both the technology and the content that we create around experiences rather than products or divisions within BHA. And by experiences, I mean, reframing buckets of content around the more colloquial ask that you might have as you're thinking about how you might engage with the BHA. So one of the things that we're thinking about is redesigning the BHA for Providers website around these more intuitive questions that you might have. So you can see they're framed as statements that start with, I need help or I need assistance. And I'm curious if I were to ask you, what are all of the things that you engage with the BHA around? Do you feel like this list is comprehensive? Is there anything that you might get rid of or edit, or you feel like we would need to add in order for this kind of organization to make the most sense?
Yeah, I can throw something out, and that's not just probably not complete, but what I've been fighting with over the years always is to find actual finance and data protocols and other rules and regulations that impact services, things like all the 837 related companion guide information, stuff that you may need to dig out occasionally, but not every day, and that then are hard to find. And I kept finding that when website is changed, a lot of that information got lost, and then I had to dig out, contact BHA and dig out information and get it sent by email because it was in an old system and not carried over to the new one. Yeah, that was my main issue in the past when websites were changed.
Yep. And so I think I was trying to bucket. So I think that kind of fits into two buckets. One of them is like, I need help with BHA reporting requirements. And the other one might be, I need help with claims and payment. Do you feel like there should be another one that kind of encompasses both of those? Or would you know kind of which of those, if these were buttons, would you know which of these to click on to get what you're describing?
I think I'll find them as long as they are there. The issue was that they were not there. So they changed the website and they had a place for it, but all the old information that was still valid and active was not carried over and could nowhere be found. That was the bigger issue.
Okay. Got it. Tamara said that she's not sure she needs the extra words, I need assistance or I need assistance with. So maybe those feel a little unnecessary. Anything you feel like is missing from this list? I would say, I think that one of the things we're also going to have, like if you would imagine this page as the website, I think right under this, we would have a section with like, frequently used links. So having, the items that we know that you're clicking on most often in a more, categorized list. So where we would be bucketing them out, say like by involuntary commitment or licensing or any number of those kind of larger categories. So there would, right under this would be sort of a place where you could find the most used links or documents. Find a form. Ron, are there forms that you're most often looking for?
Recently, we've been trying to find like updated Med9 M1 forms. We recently had a law enforcement person say that we were using an out-of-date version of the M1, but we found that that's not true because it's the same one that's on your website. But it's not easy to locate them quickly on the website.
Yep. Okay, that's great. Anything else, or anyone, is there ever, like Ron was mentioning, something you use frequently and can never seem to find on the BHA website that would be really good for us to highlight? Okay, well, more to come there. Once we get a little farther in the update of that information, I'll probably bring back some screenshots, and that's maybe something we can do in a future office hours, get some live feedback on the redesign of those pages. So that's all I have for this month. We will meet next time, September 13th, hopefully have some more detailed information on the CCAR DACODS roadmap. Then I'll stay on the line with some other folks from the BHA if people want to stay and ask questions. So we'll stay on here until 2. Otherwise, thank you for your time and your really awesome feedback, and we'll talk next month. Thanks, everyone.
Thank you.
Yeah,
Thank you.
no problem.